Professor and Chairman of Department of Surgery and Director of Organ Transplantation Center. And he'll be talking about selection and optimization of HCC patients for resection with and without cirrhosis, guidelines for hepatologists. So over to you, Professor Kim, and we'll again, start discussions once your lecture is over, and there are questions from other panelists and other listeners and ourselves as well. So to Professor Kim.
Hello, everyone. This is Dong-Shi Kim from Korea University. It is my honor to be invited to this APASL liver cancer preceptorship program. Today, my topic is selection and optimization of HCC patient for resection as a guidance for hepatologists. This is can be considered as easy or maybe very difficult, and especially as a surgeon, I was wondering what I can really offer to the hepatologist in terms of patient selection and optimization. So let's move on to the main topic. So in the world of surgical oncology, there's a very good old famous mention. So always biology is king, patient selection is queen, and technical details of surgical procedure are the prince and princess. Occasionally, the prince or princess tries to usurp the throne. They almost always fail to overcome the powerful forces of the king and queen. So, technically feasible does not mean that the resection will provide oncological benefit. So always, technical detail, surgical technique cannot win the patient selection or tumor biology. So keeping that in mind, when we select HCC patient for liver resection, as you all know, there are always fundamental consideration, which is tumor characteristics, liver function, and the performance status. So tumor characteristics such as tumor size, number, vascular invasion, or presence or absence of extrahepatic spread are the basic tumor characteristics. So it's like a TNM stage or BCLC or whatever. We have to think about tumor characteristics. And the next, we have to think about underlying liver function. So there are many different ways to measure the liver function, but especially for HCC, the liver function assessment is a part of all treatment algorithm decision. And of course, because it is surgery, we have to think about patient general performance and comorbidities, if they can tolerate major liver resection or even minor liver resections. So looking at the APASL guidelines, it already incorporated liver function and tumor number and size or extrahepatic spread, etc. So, to make decision about the treatment modality, we have to think about all these factors together. So in terms of resectability, the underlying liver function, residual liver volume after resection, and comorbidity has to be all interplay to determine resectability. And you know, underlying liver function we really cannot adjust more oftentimes, but sometimes we can adjust residual liver volume after liver resection. So these are things that surgeon can really change oftentimes. Looking at the BCRC staging system, which probably most unfavorable to surgery, they also include underlying liver function and tumor factors for the patient selection for surgery. So these three factors probably the most fundamental things that needs to be considered for patient selection for liver resection. Hepatologists probably knows all these things as much as the surgeon knows, but there are some more additional considerations for the decision for liver resection, such as tumor location. When tumor is on the surface, the resection amount probably can be minimized, but if the tumor located deep, then larger amount of liver parenchyma has to be sacrificed. And if the tumor close to major inflow or outflow to the liver, then resection volume also can be significantly influenced. And nowadays how much we resect probably is depending on what to remain after liver resection. So the remnant liver volume is very important, and those remnant liver volume has to have adequate inflow and outflow to maximally function after liver resection. So this is very famous survival graft after liver resection. It's almost 30 years ago published. So, because like all other cancer surgery, liver resection patient undergoes recurrence and survival grafts decreases over time. But if we divide these patients into the subgroups, some patient without any portal hypertension and the good liver function actually survives much longer than those patients with portal hypertension or increased bilirubin. So, the survivor, those patients in this kind of patient, those tumors were resectable, but patients survived the liver resection, but they had significantly compromised the long-term survivor because of the liver function. So, the liver function has decision to resect should not be based on simply the tumor factor alone and just simply by technical terms. The risk of postoperative morbidity and mortality secondary to liver insufficiency has to be considered, and the risk of developing complications secondary to aggravated portal hypertension after liver resection has to be considered. So, if patient, depending on patient has whether portal hypertension or not, and whether the liver resection is extent of liver resection is major or minor, these the patients can be divided into 3 different groups, and those low risk group patient group has very low very short length of stay after surgery, and very low liver related mortality after surgery. But the other group has the opposite result. So, these are pretty much the continuum of the variables that we have to keep in mind. So decision to resect should be based on chance of long-term survival rather than simply technical aspect of resection. At this point, I have to mention about the transplantation briefly, because this is still ongoing debate whether resection versus transplantation, which can provide better long-term survival, especially in early cirrhotic patient. And some meta-analysis showed that transplantation probably gives better long-term survival if we look at longer than 10 years after surgery. But the availability of graft is always the critical limit, especially in these Asian Pacific regions, and keeping the intention to deliver curative treatment all the time is always very important for the patient survival. But today I'm only focusing on the resection, keeping the transplantation away, because this is gonna be another long story. So we just reviewed about the patient selection issues, and then what will be the optimization for of surgery. So perioperative care, I would divide these into 4 different perspectives. One is the perioperative care perspective, and the liver functional perspective, and technical perspective, and oncology perspective. So perioperative care perspective, it is always very traditional, important factor for any type of surgery. So nutritional support before surgery, and cardiopulmonary rehabilitation, such as stop smoking or hypertension or blood sugar control. These are always very important for any type of surgery, and especially for HCC. So liver functional perspective is important, such as treatment of underlying liver disease using antiviral treatment, or control of portal hypertension or varices. But I think those things the hepatologists can do better, and basically we rely upon you. And for the surgical perspective, precise preoperative imaging and volume estimation is very important for the estimation of liver function after surgery. And the one important tactic that we can use for optimization of liver function after surgery is portal vein embolization. And for the technical perspective, we can choose between open versus laparoscopic, or any other type of, or even robotic surgery. And anatomical resection versus non-anatomical resection, we can choose in between. And depending on the location of tumor, especially when tumor are invading or contacting or very close to major hepatic veins, we can have some other options. And I will briefly talk about oncologic perspective optimization, which is not really well established yet, but we can go case by case. So for the imaging and volume estimation, there are many softwares, and many surgeons use different softwares and calculate the liver volume before surgery using imaging, and then value, the way the risk versus benefit of surgery, and also design the area of resection using those software. It is very important. And for the minimally invasive liver resection, those anterolateral segments are usually considered as a favorable location, but even with those posterior superior unfavorable segments, now the tumors located in those location are being resected more and more using minimally invasive techniques, using transthoracic port or 3D scope or various energy devices, or even the unusual patient position for those surgeries. So it's really changing anatomical, non-anatomical liver resection is still ongoing debate about in the treatment of liver resection. Theoretically, anatomical liver resection can provide a better local tumor control. However, anatomical liver resection has the tendency to remove more liver parenchyma. So which is better in terms of long-term survival? It's, I believe, still the juries are out, and we need more study. But if liver function enough, most surgeon would prefer anatomical resection, I believe, especially in Asian Pacific regions. And when tumor is really close to large vein, especially like the right hepatic vein, sometimes depending on the patient anatomy, we can just simply sacrifice the right hepatic vein, and especially when the patient has a good right inferior hepatic vein, you can segment. You can do segment by segmentectomy 7 and 8, and including right hepatic vein. But if patient does not really have a good right inferior hepatic vein, like in this case, we can resect the segment 7 and 8 with the right hepatic vein, and then reconstruct the right hepatic vein without vascular conduit, which we published several years ago. These are all technical variations, but to preserve more liver parenchyma after liver resection. So let's talk about some oncologic perspective. If patient has a major vascular invasion, these are kind of considered as now it is very common to undergo the systemic chemotherapy right away. But looking at the previous studies, some patients really had a good long-term survivor at after the liver resection. So then how we can choose, if we can choose those small group of patients who had a good outcome after surgery before hand, then we can maximize the role of surgery. So how we can optimize those patients from the oncology perspective? So we can, for example, in other words, how we can select those patients with advanced tumor burden, but with a favorable tumor biology. So we can use TACE, like non-curative treatment such as TACE or TARE, or even radiation therapy. Potentially nowadays some chemotherapies, and we can give them some time and looking at the response to those non-curative treatments using imaging modalities and tumor markers. But we need to keep the intention to deliver curative treatment during throughout the course of those non-curative treatments. So let me show you some example. So by doing that, we can define tumor biology leading to patient selection. We don't know how the tumor will behave at the first site, but after delivering non-curative treatment, and with the time, we can really identify the tumor biology. So let me give you some example. This is a 48-year-old patient presented with abdominal pain and jaundice. So the bilirubin was 13 milligram at the time of presentation, and the initial PIP count was almost 20,000. So there was severe bile duct dilatation on the left side, and there was a portal vein tumor thrombosis visible. So because of those initial jaundice, we did the ERCP for biliary drainage, because we thought that jaundice was from the biliary obstruction rather than liver failure. And the specimen removed from the bile duct showed only necrotic material. So after EMBD placement, the bilirubin started to decrease, but in about a week, bilirubin was not decreasing anymore. So we follow-up CT showed slightly aggravation of portal vein thrombus. So we discussed with the radiologist, and we underwent multidisciplinary discussion, and so whether discussed about the next step. Normally we don't deliver TARE to the patient with jaundice, but in this case, we believe that the jaundice was from the obstructive pattern, and so we decided to deliver TARE eventually, even though the bilirubin was high. So after TARE, so we used those TARE for both local tumor control and tumor biology test. After TARE, EMBD was placed with the ERBD and patient was discharged home. So for 1 month after TARE, bilirubin was kept decreasing and tumor marker was also decreasing. And however, portal vein thrombus at main portal vein was not decreased much, and there was actually some concern about portal flow disturbance. So surgery was scheduled. At the time of surgery, bilirubin was around 1 milligram per deciliter, and PIPCA was around 1,000. So we did the left hemipectomy plus caudate and the bile duct resection with the portal vein tumor thrombectomy. So I will skip this surgery video because of the time limitation, but after surgery, when the pathology report came back, it confirmed that R0 resection without lymph node involvement. So that overall the surgery was very similar to the Klatskin tumor. So, and after surgery, there was no specific complication and patient was discharged on post-op day 12. So far, no evidence of recurrence at 4 year, 1 month so far. So, I mean, this patient was initially very far advanced with the vascular invasion and jaundice, but we delivered the non-curative treatment first, and tumor marker nicely came down, and also during observation period there was no distant metastasis. So we underwent with the curative modality with the extensive liver surgery and obtained a very good outcome. So this is the summary and conclusion. Patient selection is always more important than surgical technique, and tumor factor, underlying liver function, and performance status are the fundamental consideration for selection of HCC patients for resection. And decision to resect should be based on chance of long-term survival rather than technical aspect of resection. And optimization of patients for resection should be considered in various perspectives, including oncologic one in advanced cases. It is important to note that the decision-making process for resection should be individualized and involve a multidisciplinary team consisting of hepatologists, hepatobiliary surgeons, radiologists, and oncologists. The team should evaluate each patient's unique characteristics and consider various factors to determine the most appropriate treatment approach. Thank you for your attention.
So indeed, it was a very comprehensive and a nice presentation. Thank you so much, Professor Kim, for such a nice insights. So I would like to have some questions from my side before I move to other questions. Like first question is how to go about caudate lobe HCCs, because that is one of the most difficult areas, being considered even difficult for interventional radiologists to treat it by ablation or chemoembolization or TARE, as you mentioned. And I would like to know what is the surgeon's perspective, because I'm an interventional radiologist. I'll be talking about more about interventions, but what is the surgeon's perspective in terms of caudate lobe HCC? That is my first question. And second question regarding optimization, like you mentioned, like liver volume, what is the remnant liver volume? That is very important. So if you consider that overall tumor is extensive, but the tumor biology and overall liver functions are good, you would go about resection. So for that, sometimes you need portal vein embolization to improve the liver volume so that you can go and resect nicely the tumor along and the adjacent liver. But would you also like to do tumor treatment while waiting for the liver to hypertrophy? Would you like to consider transarterial chemoembolization or tear in between till the time you achieve a hypertrophy of the liver? So these are the two questions from my side. And as a surgeon, your opinion on these two aspects, caudate lobe and treatment to the tumor while you are waiting for the liver to hypertrophy after portal vein embolization.
Thank you for your question. Can you hear me?
Yeah, sure. Please go ahead.
Okay, yes. So the first question about the HCC in the caudate lobe, it's a very tricky situation, as you said, especially it's very difficult to treat with the local regional treatment. But it's also the feeding the portal vein to the caudate lobe is oftentimes very small and very close to the main portal vein bifurcation. So it's very easy to have invade the portal vein invasion early at their disease course. But I think the most important issue at the time of decision making probably underlying liver function, because even for surgery in the caudate lobe, oftentimes it involves minimum left hemihepatectomy, either right hemihepatectomy. So isolated caudate lobe resection is oftentimes very much limited, not just because of the surgical technique, because it's very easy to invade the advanced adjacent right or left side liver, and oftentimes in a company have to involve a major liver resection. So I mean, as long as the liver function can tolerate, I would prefer to do surgical resection aggressively at the as early as possible, if technically feasible. And if it's not, then we probably have to do a very aggressive local regional treatment, such as like a radiation treatment, external beam radiation treatment, and then continued by the living donor liver transplantation, I would say. And regarding the portal vein embolization combination with the TACE, well, I don't have much experience combining both TACE and the PVE in my personal experience. Also, actually, not many cases, even with the, if we have to do right hemihepatectomy, I mean, HCC patient, I prefer TARE rather than portal vein embolization, because TARE can provide both portal vein embolization, local tumor control, and contralateral liver hypertrophy at the same time. And also, most of HCC patients combined with some degree of liver fibrosis or cirrhosis, which is not good for the good response, which we cannot really expect a very good response after portal vein embolization. So TARE actually provide a slower progression, slower regeneration of contralateral liver. So that's actually my personal preference.
Okay, yeah. Thank you so much for your insights. Indeed, we take your point well taken, that tear may be a better alternative to doing so. So that's another way of actually treating such kind of situation. I can see Professor Rela would also like to add something on it. So Professor Rela, please.
Hi. Professor Kim, hi, thank you for that talk. I think you brought up one type of tumor that most hepatologists wouldn't even think for resection, which is your last case presentation, where the bilirubin was high. I think it was 15, and there was a portal vein tumor thrombus. And many people believe that portal vein tumor thrombus is a contraindication for resection or transplant. And I'm glad that you brought up, because I have very similar views to that. Because if the patient will tolerate a resection, in fact, the portal vein tumor thrombus could have even caused hypertrophy of the right lobe and atrophy of the left lobe for you, like a portal vein embolization effect. And even if you consider this as a palliative procedure, it provides the best palliation for the patient. Even if the patient survives 1 year, 2 years, or 3 years with recurrence, I believe if safe resection can be performed, that's probably the best thing for the patient. Because if you didn't operate on that patient, the life expectancy of that patient would have been 3 to 6 months and no more than that, even with stenting, actually. So I think for this hepatology group, even though there isn't a lot in the literature, I hope that things will come out in the literature, that selected patients with portal vein thrombosis who will tolerate resections should be offered. And it's the same for the very large tumor. These group of patients, in fact, don't appear in the BCLC for any treatment at all, actually. In fact, surgical treatment would still be a good option for these patients. And thank you for bringing that up. I think it's very important message for people.
Yeah, thank you, Professor Rela, for adding to it. I think if Dr. Ashok has something to add.
No, we can go to the next speaker. Thank you, Professor.
Okay, fine. So next, I would like to invite none other than Professor Shuchiro Shina, who is a very known hepatologist and known for his great work on ablations. So Professor Shina would be talking about resection or ablation for early HCC, that is less than 3 nodules and less than 3 centimeter. And Professor Shina is a professor at Department of Gastroenterology, Juntendo University, Japan. And without any further delay, because he's a well-known faculty all across, I'll be moving ahead with his talk.
Mm-hmm.
So,
sorry, please.
Yeah.
Okay. So good afternoon and good evening, everybody. So today I will talk about resection and ablation for hepatocellular carcinoma. I'm Dr. Shuichiro Shina of Juntendo University, Tokyo. So first, I'd like to talk about ablation, because ablation is a general term for treatment such as ultrasound, CT, and MRI-guided insertion of needle-like applicators into tumors, killing it with heat. Radiofrequency and microwave ablations are representative examples, while cryoablation and percutaneous ethanol injections are also included. Ablation is potentially curative, minimally invasive, and easily repeatable for recurrence. And radiofrequency ablation was first introduced in Japan in 1999. Radiofrequency ablation has been the most widely used ablation technique for liver tumors. So I'd like to show a demonstrable case. This is our second case of RFA. A 48-year-old man was found to have a tumor of 3.6 centimeters adjacent to infravena cava in February 1999. And this is a CT scan 1 day after RFA, which demonstrated the entire tumor ablation. Some doctors say that radiofrequency ablation cannot ablate tumors adjacent to large vessels entirely because of the heat sink effect. However, our second case, in which we performed RFA more than 20 years ago, clearly shows that RFA can ablate the tumor completely, if it is performed skillfully. Regarding the short-term efficacy, this slide shows the anti-tumor effect of RFA in our early series. A complete ablation was achieved in 99.4%, that is 5,424 out of 5,457 of treatments. And regarding long-term survival, this slide shows the survival of 1,616 patients who underwent RFA for primary HCC. The survival rates were 62.3% at 5 years, 28.2% at 10 years, and 15.4% at 15 years. Since the ethanol injection period, we have had strong argument regarding which treatment is superior for HCC, surgical resection or percutaneous ablation. So there's a question. So today I should talk about which is better for HCC of 3 or fewer tumors, each 3 centimeters or less in diameter, resection or ablation. So there had been 4 randomized controlled trials to compare resection with ablation. Of the 4 randomized controlled trials, one showed that surgery was associated with better survival than radiofrequency ablation, whereas the other 3 did not show significant differences. The 4 randomized controlled trials had shortcomings such as lack of clear hypothesis, insufficient patient follow-up, and unknown treatment allocation. So in Japan, we conducted a multi-center randomized controlled trial, SURF trial, to compare surgery with radiofrequency ablation. 49 major centers in Japan enrolled patients with good hepatic function and HCC of 3 or fewer tumors, each 3 centimeters or less in diameter during the 6-year period of 2009 and 2015. The 301 registered patients were followed for at least 5 years. This slide shows the patient flow chart in SURF trial. And this is the final result of overall survival and this is the final result of overall survival and between surgical resection and radiofrequency ablation. The final results of SURF trial was announced in 2021. It revealed that overall survival and recurrence-free survival were not significantly different between surgery and radiofrequency ablation in HCC of 3 or fewer tumors, each 3 centimeters or less in diameter. And this is the Japanese clinical practice guideline for HCC in 2017, the previous guideline. So in this previous guideline, resection was placed above RFA, indicating that resection should be a priority. However, as a result of SURF trial and other comparative studies, the revised algorithm in 2021 treat hepatic resection and ablation equally for patients with HCC who have 3 or fewer tumors, each 3 centimeters or less in diameter. This slide shows a comparison of scars between surgical resection and ablation. Ablation is a minimally invasive therapy which does not require general anesthesia or laparotomy. And ablation is performed on patients of advanced liver cirrhosis or advanced age. So the regarding the question of which is better for HCC of 3 or fewer tumors, each 3 centimeter or resection, or centimeter in diameter, resection or ablation. I think ablation is better and because the overall survival and recurrence-free survival are not different, and ablation is much less invasive. However, there may be prerequisites. I will talk about them later. So how about ablation for HCC of 3 or more than 3 tumors or over 3 centimeter in diameter? I mean the HCC or beyond the conventional indication. So the rule, the 3-3 rule. Fewer 3 or fewer tumors, each 3 centimeter less in diameter, has been accepted as a general indication ablation for HCC. For example, this is the treatment algorithm for hepatocellular carcinoma in APASL 2017. This guideline is widely accepted in Asia Pacific area, and so local ablation is recommended for tumors of 3 or fewer tumors, each 3 centimeter or less in diameter. And this is the BCLC staging system and treatment strategy in 2022, which is widely accepted in Western world. So ablation is recommended for also for tumors of 3 or fewer tumors and each 3 centimeter or less in diameter. However, this slide shows that relationship between tumor diameter, number of tumors, and mortality risk. The prognosis of the patient with HCC worsened gradually as the diameter and number of tumors increased. No apparent threshold in the diameter or number of tumors was detected. Ablation can be applied beyond the conventional indication of 3 or fewer tumors, each 3 centimeter or less in diameter. And the similar findings have been reported in transplantation. This is so-called metroticket calculator, which shows the relationship between tumor diameter, number of tumors, and 5-year survival rate in patients who underwent liver transplantation. The prognosis of the patient who underwent liver transplantation worsened gradually as the diameter and the number of tumors increased. There was no apparent threshold, however, in the diameter or number of tumors. This calculator shows similar survival as Milan criteria can be achieved even if criteria are expanded to up to 7. So the rule of 3-3, the 3-3 rule, 3 or fewer tumors each 3 centimeter less in diameter was proposed in 1980s. The era of ethanol injection, that is, the criteria of almost 40 years ago, is used even now. During those 40 years, ablation has evolved from percutaneous ethanol injection to first-generation microwave ablation, radiofrequency ablation, and new generation microwave ablation. There is no apparent threshold of outcomes between 3 or fewer tumors and each 3 centimeter or less in diameter, and the more than 3 tumors or over 3 centimeter. So ablation for more than 3 tumors or over 3 centimeters in diameter is actually widely performed in real world. So, what aspects are needed to determine an indication of ablation? So, indication must be determined from two aspects, efficacy and safety. It is necessary for ablation to improve the expected survival rate compared with other therapies or best supportive care. And when ablation is carried out oncologically resectable cases, ablation has to be curative and eradicate the entire tumor. Indication of ablation must be determined by tumor-related factors, patient-related factors, and resource-related factors. So, in almost all treatment algorithm of HCC, treatment is determined by not only tumor factors, but also liver function, which is different from other tumors. In other tumors, treatment of choice is mainly determined by tumor factors alone. In the existing treatment algorithm, however, resource factors are not considered so much. In ablation of HCC, I think we should consider resource factors to determine the indication. And tumor-related factors include size, number, location, and conspicuity. And the patient-related factors include liver function, ECOG performance status, ASA physical status classification, and patient value. And the resource-related factors include institutional volume, operators' risk and experience, paramedic staff training, ablation system, and equipment to assist ablation, such as ultrasound, CT, MRI, ultrasound probe, fusion imaging, contrast-enhanced ultrasound, table for treatment, and more. Now I'd like to talk about new devices for large HCC. New generation microwave ablation system incorporating antenna cooling and high power generation have attracted attention. I would like to show a demonstrable case. This is an 80-year-old man who was found to have a 4 centimeter HCC beneath the diaphragm in segment 8. And we performed microwave ablation with the artificial ascites technique. CT a day after ablation showed the entire tumor necrosis. And this last slide shows the number of cases treated with RFA or microwave ablation at our institution. We have performed more microwave ablation than radiofrequency ablation recently. And the accumulated number of microwave ablation cases by December 2022 is 1,523. Many high-volume centers of ablation in Japan have introduced new generation microwave ablation for liver tumors. And now I'd like to talk about new strategies for a large number of HCC tumors. That's pharmacotherapy and ablation. And this is a treatment algorithm for hepatocellular carcinoma by APASL in 2017. So ablation is used for early HCC as potentially curative treatment, but ablation cannot be indicated for advanced HCC. On the other hand, pharmacotherapy is used for advanced HCC, which cannot be treated by either surgery or ablation. So combination of ablation and pharmacotherapy may build a new treatment strategy. I would like to show a demonstrable case. This is a 72-year-old man with taste refractory HCC treated with lenvatinib and ablation. And this figure shows a condition of HCC before starting lenvatinib, October 2019. He underwent hepatectomy and he underwent 6 times of TACE. However, he was judged refractory to case, and he was referred to us. And we started lenvatinib on October 2019. And this was the largest tumor, 7 centimeter in diameter and continuous with infravena cover. And this is a second tumor, and a third tumor, fourth tumor, fifth tumor near the surface of the liver and lipid deposit, and sixth tumor. So he had at least 6 tumors, the largest 7 centimeter in diameter. And this is a CT scan 12 weeks after lenvatinib. After 12 weeks of lenvatinib, the largest tumor lost vascularity and shrunk from 70 millimeter to 56 millimeter. However, this tumor enlarged. Hypervascularity remained in 3, 2 enlarged and the other unchanged. So on January 2020, we decided to perform microwave ablation for the 3 tumors. And on April 2020, we performed second microwave ablation for the other 2 tumors because contrast-enhanced ultrasound detected vascularity in them at that time. So, and this is the MRI taken on June 24, 2022. So we stopped lenvatinib 2 months after the second ablation, and for more than 2 years, he has not received any treatment for HCC, not either pharmacotherapy or ablation. We have 21 cases in which the combination of pharmacotherapy and ablation has achieved complete response. So we think combination of pharmacotherapy and ablation may build a new treatment strategy. Incidentally, ablation has problems. Ablation appears a relatively simple procedure. Thus, some doctors may perform ablation without sufficient training. And ablation is possible to be performed even with inexpensive, poorly performing equipment. Thus, ablation may be performed under inappropriate circumstances in some institutions. So, I would like to talk about education in ablation. So, in order to raise the level of ablation as a whole, we held ablation training programs. Programs were composed of comprehensive lectures, live demonstrations, and case studies. And the context of lectures include current status of ablation, ablation devices, ultrasonography, and others. And we perform radiofrequency ablation or microwave ablation on 3 to 4 cases per half day using artificial ascites, artificial pleural effusion, contrast-enhanced ultrasound guidance, and fusion imaging method. In the 5-day program, you will be able to see 12 to 15 cases of live demonstrations. And in case studies, difficult to ablate cases from participant hospitals are presented and discussed. This slide shows a total of 237 participants in the first to 14th domestic ablation training programs. And we also have the international programs. And this slide shows a total of 111 participants in the 1st to 7th international ablation training programs. And we will resume the domestic and international ablation training programs after almost more than 3 years interval due to the COVID-19 pandemic. And the next international ablation training program will be held September 12th to 16th this year. And I'd like to talk about a little about artificial intelligence for ablation. artificial intelligence is said to have the potential to assist ablation in terms of modeling, planning, monitoring, and assessment. I am hopeful that in the very near future, artificial intelligence will play a role in assessing whether a tumor has been completely ablated or not. AI has a potential to offload the time-consuming process of comparing pre- and post-ablation images. And I would like to summarize my talk. As a result of the multi-center randomized controlled trial in Japan, SAF trial, and others, the recent treatment algorithm treats hepatic resection and ablation equally for patients with HCC of 3 or fewer tumors, each 3 centimeter or less in diameter. Compared with surgery, ablation is much less invasive. The indication of ablation will be expanded in the near future. Microwave ablation can create more predictable, larger ablation area in a shorter procedure time. Combination of pharmacotherapy and ablation may build a new treatment strategy for advanced HCC. Cure can be achieved in selected advanced HCC. And education is important in ablation to spread skills and know-how and standardize the procedure. Artificial intelligence and other technologies will further improve outcomes in ablation. Ablation is expected to play an increasingly important role in an aging society. Finally, I would like to say a few words about APASL 2020 for Kyoto, the Center of Hepatology. The 33rd annual conference of APASL will be held from March 27th to 31st next year during the cherry blossom seasons. And abstract submission and registration will begin on July 1st. We will welcome all of you in the ancient capital of Japan with cherry blossoms in full bloom. Thank you very much.
Thank you so much, Professor Sheena, for a very elaborative and a nice talk, and also talking about different aspects regarding education in ablation, and touching out multiple aspects of ablation and ablative therapy and comparing surgery versus ablation. So I would just like to ask one question, like how would you consider surgery versus ablation in two scenarios? One is pericholecystic tumors, which is on the surface. So very much it is an exophytic lesion indenting upon the gallbladder lumen. So one question. The second question is like central tumors, which is very close to bile ducts or bile duct radicals. So those tumors, because we know that we are not going to do perivascular tumors, or we will take adequate precautions for perivascular tumors, but most of the patients don't have biliary dilatation. We just see some linear things going along or adjacent to it. So how to avoid, because these tumors may lead to biliary injury and biliary dilatation. So pericholecystic lesions and lesion close to bile duct. So would you consider surgery above resection, or still you would consider ablation over surgery?
Yeah. So first, the question is whether the tumor, when the tumor is located on the surface of the liver, whether we should perform ablation or not. So we don't have we perform ablation, almost all cases of tumor located on the surface of the liver. It's no problem because of course, if the tumor is located on the surface of the liver, we need artificial ascites technique to make a distance between abdominal wall and the tumor to separate the tumor from the abdominal wall. And we should not insert the applicator directly into the tumor, because it may increase the chance of dissemination. So through the non-cancerous teeth, we insert the applicator into the tumor and ablate. So in many times we need to do the overlapping ablation, but on the surface of the tumor, it's not so difficult to ablate the entire tumor. And the second question is a very good question, because if the tumor is located near the bile duct, in that case, we sometimes hesitate to perform ablation. We should consider, because so in case of hepatic vein, we are not so, we don't think it's risky, but in case of intrahepatic bile duct, intrahepatic bile duct is easy to be injured by heat. So what we think is whether we should ablate the entire tumor, and even if we sacrifice that that peripheral, if we have that area, I mean, if we ablate a tumor, sometimes the peripheral area will be so there will be dilated hepatic bile duct, intrahepatic bile duct, and in the long run, the area will be become atrophic. So, and it may deteriorate liver function. But sometimes, if the bile duct is not the main bile duct, we think sometimes we think we should ablate. Even with the stricture of the intrahepatic bile duct occurs. But if the bile duct is very near to the porta hepatis, in that case, we hesitate, and we sometimes choose, if the patient is not a good candidate of surgery, in that case, we may use the radiotherapy, like the cyberknife or others.
Okay,
Yeah.
thank you so much for an elaborative answer. First, I would like one question to be presented before you by Dr. Diana. She wants to know the option for HCC with partial obstruction of portal vein. So she would like to know whether you think immunotherapy may be an option in combination with ablation. And second question, also from Dr. Diana, where she would like to know the settings of microwave ablation starting point. Does he start on high temperature or low temperature and gradually increase?
So the first question, whether if the tumor is so partial occlusion of the portal vein, in that case, I don't think the ablation is a treatment of choice. I don't, in that case, maybe, so we will do the other therapies. So pharmacotherapy or radiation, like the pharmacotherapy or radiation would be a treatment of choice. And if we perform pharmacotherapy and the invasion of the portal vein disappeared, in that case, we can consider ablation as a treatment of choice. But with the so we may perform ablation, maybe so after the portal vein invasion disappears. And the second question, whether we increase the how is the output of microwave ablation? So we would like to increase the output gradually, because in order to avoid popping, because popping means the sudden increase of the pressure inside the ablated area. So we would like to avoid popping because we think popping may enhance may increase the chance of dissemination or something. So we would like to increase, like the 45 watt for 1 minute, 60 watt for 1 minute, 75 watt for 1 minute, and then 100 watt, like that.
Okay, thank you so much. I think Professor Abbas has some question, and then we'll quickly take a question from Professor Rela and move on to the next topic. And there are some questions in the question answer section. If you have some time, you can just go through it. Professor Sheena.
Thank you very much, Professor Sheena, for a very elaborate talk. What's your experience of combining ablation with TACE, like the tumors that are of intermediate size, like 3 to 5 centimeter? Either therapy may not be sufficient to completely ablate the tumor. So combining TACE with ablation, what is the experience in your center?
So as a general rule, we don't combine TACE with ablation because the ablation, the local effect of ablation is much stronger than TACE. So we don't think it's necessary to combine and the both therapy. Ablation is enough, we think. But some doctors say the combination of TACE with ablation will increase the size of the ablated layer ablation, but we don't think so. We don't combine ablation TACE with ablation. But in some cases, so they received TACE at other hospitals and they were referred to us. Them in that case, there's a case of TACE with ablation, but as a general rule, in my institution, we don't combine at all.
So Professor Rela has some question.
Just a quick question. I noted from your experience in 2022, 80% of the cases are really microwave ablation rather than radiofrequency ablation. So obviously, you're suggesting to us that the microwave is superior now to RFA. Is that true that RFA will be phased out and microwave will win over?
I'm not sure because that's
your experience. You've demonstrated most of the cases you do now.
Yeah, we performed a randomized control trial between RFA and microwave ablation. I'm sorry, we haven't published it yet, but there's no difference between the two ablations from in terms of efficacy and safety. So if you are so it's up to the operator. If the operator prefers microwave ablation is okay. And if the operator prefers radiofrequency ablation.
But you're the world expert. You seem to have switched to microwave. 80% of your cases are microwave in 2022.
Yes, that's true. Yeah.
Okay.
So
you still don't want to say microwave
because we can so if we use microwave ablation, we can treat more patients in 1 day. So that's why we use microwave ablation. Actually.
So
thank you.
Quickly, just adding one more comment to it. If you talk about India, Professor Rela, yes, we are moving more towards microwave ablation from RFA. Though the data is still, more like the ablation zones are more or less similar. But because of the ease of inserting and doing the ablation in 2 minutes, 3 minutes, and increasing the patient throughput, and more so not tackling very hard with heat sink effect. Yes, we are moving towards microwave ablation. We don't know whether RFA is going to be phased out, but in India, yes, we are moving towards microwave ablation. So anyway,
thank you.
So that was.
This is now winning over efficacy, which is equal.
Yeah. Definitely. So anyway, so thank you so much, Professor Sheena, for answering all the questions nicely. And still there are many more questions in the question answer box. If you find some time, you can just go through it. But before, just thanking you again for your very informative lecture. And next, I would like to invite none other than Professor Rela for his next grand rounds. That is the case vignettes, and which would be very, very informative, and probably we'll get to know more about it. And just a quick words about Professor Rela, though he is a very well-known personality. He is the chairman and director for Dr. Rela Hospital, India, and professor of liver surgery and transplantation at King's College Hospital, London. So it will take a while to discuss more about him, but since he is a well-known, I'll simply invite him for the next deliberation. Probably his cases would be presented by his some colleague, and he'll be discussing it later on.
Okay. Thank you. I want to thank Professor Sareen and APASL for this invitation. What I'm planning to do is to have some case presentation, and I'll intervene and ask some questions, and it will be interactive. It's going to be interactive between me and my team, and if anybody wants to just come in and ask questions also, we can do that. I've got 2 cases, and if time permits, maybe 3 cases. In fact, both the presenters have done cases which are unique, actually, which I liked in your own presentation. And this will be maybe a little slower presentation. Who's presenting? Is Naveen presenting the first case, or from my side? Is that Vasant there? I can see.
I'm presenting, bro. Vasant presenting.
Okay, all right. This is to really reinforce, I think this case is to reinforce what Professor Kim presented with a portal vein tumor thrombus. I mean, very large tumors in the early cirrhosis or non-cirrhotic, which, I mean, the BCLCs is primarily a cirrhotic patients who have no options but surgery is the kind of message that I wanted to bring through this case. Go on.
Thank you, Prof. Good evening, ladies and gentlemen. I would present the first case. My patient is an 18-year-old girl who presented to us with hypertension. And she came to us with abdominal fullness for 1 year, and she had increased abdominal pain for 2 months. She also had significant weight loss with anorexia, no jaundice or ascites or any renal impairment, no gastrointestinal bleeding. She was evaluated elsewhere for all these complaints. Her viral markers were negative. An ultrasound showed a large liver mass. They had done an FNAC which showed no malignant cells. With this, she presented to us to our institute in April 2022 for further treatment. Her investigations, baseline investigations were normal. Her liver function tests were normal. Her platelets were 5,77,000. Apart from that, everything was normal. Tumor markers, AFP was normal, but PUCA was 33,000, and the other rest of the tumor markers were normal. So this is a CT scan, which we first. It's a large heterogeneously enhancing mass with an arterial enhancement scars in the intervening tissues. And this is a portal face which shows a huge mass of 20 cross 25 centimeter involving almost the segment 8 and the whole of the left lobe. And
Is
the
your
portal vein was
connection or am I connection? Connections.
So this is a venous face which shows the patent artery. Prof?
I can't hear you well. I don't know if your connection is not good. Can you? We can't see it properly, guys. Ask him to connect to a phone. Can you show the other face? Sorry. I mean, I just want, we have another surgeon, Professor Kim, here. So this was a very, very large tumor, about 25 centimeters in size. It looks like potentially a non-cirrhotic in an 18-year-old girl. And it is really stretching the right hepatic vein. The right posterior sector may be free. For segment 6 and 7 may be free, but the tumor is really compressing the right hepatic vein. So it's a kind of a borderline resectable tumor. Now we are there back again. Can you see? Are you guys there?
Yeah, please carry
Is it
on.
audible, Prof?
Yeah, now we can do. Yeah.
Oh, sorry.
Show us the venous face.
Yes, Prof. So this is a venous face, which shows the compressed IVC with the patent right hepatic vein. And the main portal vein and the right anterior, right posterior portal vein were patent, and the left portal vein was not visible, and the right hepatic
You can
vein
also see that there is compression of the bile ducts. There is dilatation of the right posterior ducts. Yeah. Okay. So, I mean,
with this
yeah, go on. Yeah. Finish all the presentation.
yes. So with this, this is the borderline resectable case, and decided to proceed with surgery. So we took her for surgery, and the plan was to do a left trisectionectomy. We had to use a chin, and we completed the left trisectomy, and she greatly anastomosed to the rulum. And the intraoperative details, she had a blood loss of 2 liters, and blood transfusion. She received 6 red cell transfusions and 1 plasma. It was 8.1, and the end lactate was. So the hospital coded 1 plasma on the second day, uneventful postoperative recovery, and she was discharged on day 10. So this was her postoperative labs, 200, and ALT was 1200. And on day 10, she was discharged with almost normal LFT. Her Billy was 2.60, which came down to normal levels in the postoperative period. I mean, in the postoperative follow-up. So to go about with the histology, the first picture shows the tumor with the capsule, and the second slide shows the well-differentiated tumor cells. So the histology was showing a 26 centimeter tumor, which was well-differentiated, which was a WHO grade 1 with no necrosis and free surgical margins. We didn't identify any microvascular, macrovascular, or perineural invasion, and all the margins were negative. And the non-tumoral liver tissue was not showing any cirrhosis, any features of cirrhosis. So this is a follow-up CT, which was done at 4 months. Her liver functions were normal. The normal AFP and the Q considerably reduced to 25. We could see a beautiful liver remnant. And this is her follow-up at 15 months. We got a PET CT to look for recurrence. There were no lesions, and her LFT was normal, and PUCA and AFP both were normal.
Thank you. I think I just want people, if there is anybody, any comments I'd like to see. I mean, this is a very young girl, 18, 19-year-old. Really, I felt that the resection was the only option. I wasn't even sure if we could give a clearance of the right hepatic vein, because the right hepatic vein was really adherent to the capsule of the tumor. But I didn't think there was any other option. I wonder if people would comment on whether TARE should have been tried first to shrink the tumor before the resection. but cost is a huge issue in our country for TARE. TACE for such a large tumor is absolutely not an indication. And I felt that surgery was probably the best option. Is there any view on that? I mean,
So,
she's now 15 months with no evidence of any recurrence, and the PIVCA is 21.
Yeah, indeed. First of all, I would like to congratulate you, Professor Rela, for a wonderful resection and a wonderful follow-up. At 15 months, having no recurrence itself shows like how good it has been resected, and the patient was discharged on post-op day 10. So, as far as therapies pertaining to interventions are concerned, like TARE or TACE, so totally agree. Like TACE was never an option. Ablation is not an option. So, coming to TARE, yes, we could have tried, but with just idea to shrink the tumor and not to treat the tumor. So ultimately, the patient had to undergo a surgery. And despite being a large 25 centimeter tumor, you did a wonderful job. So kudos, all thumbs up for you. So,
I wanted to finally discuss these, out of recommendation resection, because there is a lot of literature, and I want Professor Kim to join that. Can we go on to see what else? And the other thing I wanted to discuss was very high PIVCA with normal AFP. It's quite common, I guess, because in the case that Professor Kim presented also, I noticed that the AFP was 17 and the PIVCA was 19,000. So, and do you have a situation where it can be reversed, where you can have a high AFP with negative PIVCA? Does anybody wants to comment on that? Or Ashwin, did you say something about that? Can you go to the next one? I thought I wanted to discuss that because there are a lot of young people here where we need to make them understand that you can have a normal AFP and a very high PIVCA, or a very high AFP and a negative PIVCA. Yeah.
AFP is the most studied HCC biomarker for liver for the recurrence of HCC. But the sensitivity is 39% to 64%. Specificity is high, 76% to 91%. The value of AFP, if it is less than 100, it's very specific. If it is more than 1,000, it's very sensitive in predicting recurrence. Increasing AFP after downstaging therapies indicate aggressive tumor biology and recurrence. It can predict high recurrence rates even in tumors within Milan criteria. Only 40%, 60% of HCC tumors can produce AFP, 40% don't produce AFP. So in those patients, they have normal AFP levels. Coming to the PIVCA, it predicts recurrences after resection. The overall sensitivity is better than AFP. It is 48 to 62%, and the overall sensitivity is also higher than AFP. A multivariate analysis performed on 144 HCC patients who underwent LDLT. It says more than 400 was an independent risk factor for tumor recurrence after transplant. So it shows aggressiveness of the HCC, but the clinical relevance is still under debate. So these are the few extended criteria where they've included the tumor markers, AFP and PIVCA. If you see this Takada, up to 10 lesions, they have used PIVCA less than or equal to 400 for HCC liver transplantation. In Fujika paper, they mentioned less than or equal to 400.
Yeah, which is a kind of a surprise for me, because up to 10 tumors doesn't seem to matter. But what seemed to matter is a PIVCA greater than 400. And here we have situations where we are operating on patients' resections with PIVCA greater than 20,000 and 30,000. Professor Zangam Abbas, do you want to say something? You've had your...
Yes, because I was just wondering that, like in our center in Karachi, we are doing both biomarkers like alpha-fetoprotein and PIVCA. And you are right that these two biomarkers do not go together. And many times we see very high PIVCA score, but not very much elevated alpha-fetoprotein, or alpha-fetoprotein is normal. In your case, the PIVCA was very much high, like in thousands. So I was just wondering that after resection, what are the chances of having tumor recurrence? And should we consider in these high PIVCA cases giving some sort of chemotherapeutic agent like sorafenib or lenvatinib after complete resection.
I think it's interesting. I mean, I put this forward for a reason. See, people in the West, this is a very Eastern thing that the PIVCA has been done routinely, and we also do both. So people in the West use AFP, and AFP of over 1,000 is a contraindication for transplant. The UK criteria takes away AFP of more than 1,000 for transplant. I mean, forget about the size of the tumor. I'm talking about patients within criteria. With AFPs over 1,000, it's a contraindication for transplant. But you could have an AFP which is less than 100 and a PIVCA of 20,000. And if it is not done, the patient would be a candidate for transplant. So there is still not a very widely accepted understanding that the AFP can be normal, but biologically they may not, because it's normal, biologically they're not necessarily good tumors because their PIVCA can be extremely high if you do it. And the PIVCA is still not incorporated in the Western indication for transplant. Can we move on? I just want to move on with this because we've got another case. Can we look at the tumors greater than 10 centimeters and the outcome? Yeah.
Dr. Kim has something to say. So, yes,
Dr.
Kim.
Coming to the,
Hold on. Dr. Kim, can you say?
In my case, I think the patient had obviously very high bilirubin and bile duct obstruction, especially on the left side of liver. The bile duct dilatation was very evident. So I think the part of the PIVCA was obviously influenced by the biliary obstruction in my case, and I am not exactly sure how bad was the biliary obstruction on your case, but the bile duct dilatation was also a little bit visible. And the big difference from your presented case and my case was the presence of vascular invasion, portal vein invasion. So in my case, portal vein invasion was very evident at the beginning of the case, like VP4. So in such case, I would be very hesitant to go to the surgery right at the presentation. So that's why we underwent TARE first. But in this presented your case, even though the left hepatic vein was not visible on the imaging study, there was also not a good evidence that there is a significant vascular invasion identified on the imaging scan. So in other words, it's like a single huge tumor without clear evidence of vascular invasion. I think that's the very and also very good underlying liver function. So I think that's the best.
I agree with you. I agree. My question
is the best option.
Yeah, my question was whether TARE would have just made it move away from the right hepatic vein, because the right hepatic vein was so compressed. The resection was very bloody in the beginning. So I had to do a total vascular exclusion for almost 45 to 50 minutes to complete the resection. So there was a very long warm ischemic time for the liver because I had to clamp the inflow, outflow, the caver, the whole thing had to be clamped to actually complete the resection, because we literally had to peel it off the right hepatic vein. Maybe a TARE could have actually shrunk it a little bit to allow the right hepatic vein to be open. That was a question. Finally, I think we finish off with this slide. Because large tumors greater than 10 centimeters in cirrhotics don't actually come in the B. If you look at BCLC, there is no true treatment option for them unless they are non-cirrhotic. I'm talking about cirrhotics, but there is now enough evidence in the literature that large tumors greater than 10 centimeters also do well. Can you just quickly go through that and then we move on to the next case?
This was a multi-institutional long-term observational study which compared HCC patients with more than 10 centimeter in two eras. One was done in 2000, between 80s and 2000, and the other one from 2002 to 2015. It shows a significant reduction in surgical mortality at 2.1 now in the recent current study. And if you see the disease-free survival and the overall survival, the 5-year overall survival has improved significantly, 16.7% earlier, and now it is 46.2%. And they have compared a TACE versus surgical resection in these patients, and they've said that in selected patients, surgery is better than transarterial chemoembolization. And coming to the BCLS, again, tumors greater than 10 centimeter are not incorporated in BCLS criteria yet.
Okay.
The take home from this is in that same series of about 4,000 odd patients, and which came from Taiwan over about 20 years. What they noticed was those which were actually within 5 centimeters, they compared that series with those which were about 10 centimeters. The 1-year and 5-year survival was actually quite poor in the 10-year in the over 10 centimeter tumors. But what was heartening was that this survival with surgical resection was much, much better than not doing anything or doing TACE. So I think that is what we would like to sort of be the.
Thank you. Shall we move to the second one? Ashok, you want us to move on, don't you? Or yeah, please. And then if there is time, we can talk about further cases. Okay. So we're not talking about transplantation today. This is again a resection for smaller tumors, but this is go on. You'll understand it's a very indolent tumor, repeated resections and multiple resections. Go on. Naveen is presenting. He's our hepatology unit. He's also from ILBS. He's come to us from ILBS. Naveen.
Thank you, sir. And I'll be presenting a patient, Mr. X, who is a 60-year-old male from Myanmar, who has no comorbidities in the background. In 2012, he had a right upper quadrant pain, diagnosed to have hep B cirrhosis with a HCC in the segment 7. We don't have the size of the tumor or the biological values AFPs, but he underwent right posterior hepatectomy at Myanmar. And 1 year later, there was a new lesion in segment 2 for which alcohol ablation was done. 4 years down the lane, he also developed a recurrence in segment 2 and a new lesion in segment 7, for which TACE and RFA was done in Singapore. Subsequently, 6 years later, during the routine follow-up, he noticed the rise in AFP levels, and because of this, he came to Reda Hospital. And the investigations in November 22 said he had a slightly lower platelet count, a mild thrombocytopenia.
When was the first tumor? This is 22. The first diagnosis was when?
To 2012, 10 years ago.
Yeah. So this is actually a 10-year history of a patient with hepatitis B cirrhosis who keeps cropping up with tumors, which has been resected, alcohol ablated, TACE, RFA, practically everything has been thrown at it. So one message out of it is that this is a tumor with good biology, or this is a patient who's developing tumors of good biology. He's still alive 10 years on from the date of presentation. Go on.
And he had a mild thrombocytopenia and INR was normal, bilirubin of 0.4. The AFP levels were 297. He's a child A and mild of 8. And there was no significant portal hypertension. And this was the imaging, which showed there is in the segment 2 and 3, there was an arterial enhancing with a significant washout with a thin enhancing capsule. And also there was this measured about 7.5 into 5 centimeter in diameter. And there was another lesion in the segment 8, which was faint around 1 centimeter in size, which with a significant washout. So the diagnosis was the hep B-related cirrhosis with no significant portal hypertension, but otherwise compensated. We had a multifocal HCC, post-hepatectomy, post-alcohol ablation, post-TACE and RFAs. And currently he is outside Milan and outside UCSF criteria. So what would be the best treatment option in this case? Whether to go for an upfront liver transplantation, considering this has been a good biologically indolent tumor, or resection, or loco-regional therapy, or it would be a downstaging followed by liver transplant.
I'd like some comment actually from the panel which is here. I mean, I probably would have offered him liver transplantation, even though it's outside UCSF criteria. I mean, we follow UCSF criteria because of good tumor biology. Any comment on this? Professor Kim?
Yeah, I would also recommend the liver transplantation, but only after local regional treatment and showing the nice decrease in the alpha-fetoprotein and the response to the local regional treatment. This patient, even though had a long history, had multiple recurrences so far, and now patient has a multiple tumor at the same time. So probably transplantation will provide a better survivor in the long term, but we need
the last
test.
one. Yeah, down staging followed by liver transplant, which is really what we offered. Zangam, Abbas?
Yes, I would go for liver transplantation because the Milan criteria and UCSF criteria are basically for the cadaveric donation, but in our Asian countries, we go for the living donor liver transplantation. And the history, if you see the patient has survived for the last 10 years and everything has been done before. So I would say that I would go for liver transplantation.
Yeah, but we should also have some criteria. We can't just say we have no criteria as long as there is no extrahepatic disease. I mean, we are still following UCSF. But I agree that if it's a downstageable tumor, my argument for transplantation for him would be the good tumor biology and the long history of tumor there, which has been controlled with other treatment options. So that would be a very good.
Again, in this case, I would consider giving after transplantation some chemotherapeutic agent like sorafenib or lenvatinib. Just for any embolic
he's never had extrahepatic disease all these years.
Yeah.
10 years he's had no extrahepatic disease. So let's see because there is now a patient choice as well. Let's see, the patient actually turned down downstaging and transplantation. So go on, can you tell us what we did?
Yes, sir. We offered the patient actually downstaging followed by liver transplant, but the patient was not keen for a liver transplant, and he just opted for the local regional therapy. So he underwent TACE to the segment 2 and 3rd lesion, and the segment 8 lesion was left. We thought we'd let a bit increase in the size, and we'll do it in the follow-up period. And this was the scan at follow-up at 6 weeks. And we can see there was a more than 60% of the lesion shows necrosis, and only there is a faint arterial enhancement in the posterior aspect of the segment 2 and 3, and which has a significant washout. So it's only, it showed a partial response, and we wanted to look follow further for 3 months, and we increased the lenvatinib, which was initially 4 mg, which we tolerated, currently to 8 mg, and we gave a plan to follow up after 3 months. That is after 6 more weeks from this scan. However, the patient went back to Myanmar and he didn't follow up at that time, and he came to us after 5 months. And this was a scan at the 5 months, and there is again the residual tumor measuring around 4 to into 3.5 centimeter in the segment 2 and 3, which is faint. It shows arterial enhancement with a washout, and the size of the previous tumor in the segment 8 has slightly increased as to 1.5 centimeter with a significant washout. So
now this has been downstage to within UCSF, hasn't it? So still this is showing good tumor biology. I would still suggest to him that he should opt for a transplant. Okay, go on, continue.
So now the current values are again still is in the child A, preserved liver function with a MEL9 and successfully downstage. Now what are our options? Is a liver transplantation now, or the repeat of a local regional therapy, or resection, or just to continue with the oral tyrosine kinase inhibitors? And since the patient, we offered again transplant to the patient, and the patient again denied for the transplant, and then now we chose for a resection.
Okay, go on, tell us what. I mean, I think he's just had a resection. Go on, show us.
Yeah, he just had a resection a week back. This guy, we did a non-anatomical wedge resection of the segment 2 and 3 tumor along with the tumor mass, and a wide local excision of the segment 8 lesion. And the tumor histology wise, it was a moderately differentiated HCC with a microvascular invasion, with a no macrovascular invasion, and surgical margins are free. Perineural invasion is absent, and the tumor immunohistochemistry is suggestive of HCC, and the non-tumor liver is suggestive of cirrhosis. So, what?
So post-operatively, then now what do we do? I mean, he's bound to get another tumor, isn't he? Anybody else on how do we, what can we offer him post-op? Just lenvatinib, continue with lenvatinib and wait for another tumor to come after 1 year, 2 years. Maybe he'll agree for a liver transplant at that time if he's lucky. Or if he comes back with a lung metastasis or something, he's in trouble. Any other suggestions that we can think of? Is there any other suggestion you have, Naveen?
Yes, sir.
Okay, he's actually just had the resection. He's not even been discharged.
Yes, sir.
Yeah, go on.
Hospital. And coming to the tyrosine kinase inhibitors after resection, going through the data, the first Segment phase 3 trial was published in 2015, which included nearly 1,000 patients, where it was a multicentric trial over 28 countries, a double-blind randomized control trial, where sorafenib was tried in patients who underwent post-resection as well as ablation, and it was showed there was no difference in the median recurrence-free survival. And subsequent results also said the same, except for these two trials. And this was published by Zhang et al. In 2019, which included 730 odd patients, where they found that sorafenib after resection had a good overall survival as well as recurrence-free survival significantly better. And especially they included patients who had an R0 resection plus those who had a microvascular invasion. And subsequently, in 2021, one meta-analysis was published, including 13 studies and showing 2,600 odd patients, which showed their superior overall survival as well as the recurrence-free survival with sorafenib when added in adjuvant to resection. And they had a significant lower recurrence rate in the follow-up. However, still the APASL guidelines published in 2018 and the INASL guidelines in 2019 do not favor the use of adjuvant sorafenib after liver resection. Coming to
yeah, go on.
Coming to lenvatinib after resection, there is not much data after lenvatinib after resection. Most of the data is on lenvatinib after liver transplant, which shows there is a significant improvement in the recurrence-free survival. After liver resection, there is only one study which was recently published. That too, it's in a preliminary report involving only 50 patients. This trial was from China, where they have given lenvatinib was started after 4 to 6 weeks of resection, and they have selected patients who, according to the Chinese Liver Cancer Society, they criteria, and which when compared to the BCLC, it compares to the A and B and selected BCLC patients, where lenvatinib was shown to increase the median recurrence-free survival by 16.5 months. Their previous mean survival was 9.03 months. And so they have suggested there is an improvement with lenvatinib after resection. And this...
What do we do? Can you go back? Go back. Lenvatinib or sorafenib or nothing for this patient? Okay, let's just talk about, is there any comment on how we should manage him? Or can we simply say, when you're ready for a transplant, come back, we'll do a transplant? You saw the shape of his liver. I mean, he's cirrhotic, his child's A, has had a resection. Do we just simply tell him it has to be a transplant the next time around? And how do we reduce that risk? Is there any way of reducing? I personally don't think there is. Can you put the third option as a final option for him?
So there is a talk on this adjuvant TACE following resection. This is what's called PA-TACE, that is post-ablative adjuvant TACE. And there is a lot of data on this. Here, the patient, I have just taken the RC meta-analysis published. First in the year 2019, where 26 studies, including 7,800 patients were published. It showed that those patients who underwent post-adjuvant TACE subsequent to resection had a significant 2 to 5 year overall improvement in the overall survival by an odds ratio of 2.4 and a disease-free recurrence survival rate of odds ratio of 1.85. And they suggested this was a specific subgroups to those who have patient who have a microvascular invasion and even portal vein tumor thrombosis not involving the main trunk. And there are significant satellite nodules and when the margins of resection are less than 1 centimeter free from the tumor. Subsequently, another meta-analysis published in 2020, which included 40 studies and more than 10,000 patients, including 10 RCTs. This also showed the similar results of increased overall survival and the disease-free survival. And the same, these preferred subgroups were those patients who had a microvascular invasion and tumor more than 5 centimeter, and those patients who had a multinodular tumors. And the last meta-analysis published in 2021, this included only the randomized control trials, and which included nearly 1,200 patients, which showed the similar results. And the interval between the resection and TACE in all these trials was ranges from 2 weeks to 12 weeks post-resection.
Now, I think this is an interesting concept, and I've tried it in a few patients, and I have to say that I've not had a hugely positive outcome out of it. I think the principle of this, which is transarterial, whether it is simple chemotherapy or even TACE, post-resection, when there is no tumor in the residual liver, is with an idea that these tumors are multifocal. Maybe there is a microscopic tumor on the other side that you can't visibly see today and might come up in 1 year time or 6 months time. Potentially, you're dealing with disease that is not actually radiologically visible, would be the concept of adjuvant TACE post-resection in the remnant liver that is left behind. Obviously, you have to wait for the liver to regenerate or at least have a good remnant before you can actually do either simply a transarterial chemotherapy or even a TACE. Has anybody got any opinion about that? Because even though many people, I mean, I was talking about this in one of the consensus meetings in IANSL. Many of the hepatologists in India were surprised about this as an option for patients, but you've got actually RCTs and large number of patients who have had this as an option. So I just wanted to put this as a discussion point. And after which I think we have another case. I think we'll stop with this, I think, because I have
a question for Naveen. So in these RCTs, where these R0 resection or there were R1 resection, because if it is R0 resection, it is still pretty odd. I'm not sure where.
We are talking about R0. It is R0 resection.
It is R0 resection, sir. Sir, here the concept is we are not targeting any specific tumor. There is no residual lesion, visible lesion. Here, the concept of TACE was only that the lipoidal solution is taken up by only the tumor cells and not by the rest of the cells. The tumor cells have a specific membrane protein that absorbs the lipoidal cells. So if there is any microvascular multicentric HCC that is left over in the residual liver, that specifically takes up the lipoidal, and that causes the tumors to embolize itself. And that is the concept behind it, and we are not targeting a specific residual lesion that is left after resection, sir.
No, so well, thank you so much for elaborating on it. Then I'll rather say that with upcoming technologies like cone beam CT, you have a cone beam CT, you can do a good pressure injector based injection into hepatic artery, and you can do a triple phasic scan after that, and that will give you multiple small nodules if they are not even seen on CT scan. So that can be seen, and if it is there, it can be targeted. But if there are none, then there is no point doing a TACE, as far as my experience.
You're still talking about something which is visible. We are talking about cancer.
Points well taken, Professor Rela. So it's not about the lesions. These are the lesions which is picked up on cone beam CTs are definitely not seen on routine CT, even on MRI. So I'm talking about the lesions which were never seen, and now people are picking it up more and more. While
you're still talking about a lesion which is seen in a different modality. I'm talking about a cluster of 100 cells. No modality will see that. That is the concept of this, that if there is tumor cells, if there are new tumors which are formed in the opposite side, that is potentially you might see after a year is what is being picked up by this. That is the concept of it anyway. So it's something that many people have done, and whether this would constitute an option for patient post-resection is what I wanted to put this as a discussion point. Dr. Abbas put his hand up. Is there anybody else? I think we need to conclude soon. I have to go as well.
So
Anybody
even
else?
we are, I think I'll just see the question answer chat box. If there are any questions, there are none on the chat box.
May I say something? Dr. Abbas here.
Yeah, please carry on, sir.
Okay. In the TACE, the concept is TACE is transarterial chemoembolization. So this is not only the putting the lipoidal, but you have to embolize the things also. So what portion we are going to embolize if we are not able to see any blush? So this is the query that I would ask Professor Ella to answer. It may be that we in our center practice doing TACE, like sometimes we see the tumor cell, the things that are not clear on CT scan. Then we do the this angiography, and we want to see any tumor blush that may be the cause of elevated PIVKA or alpha-fetoprotein. But if after you have done the full resection, so I am not sure if you are not able to see any blush, how you are going to embolize and what part you are going to
No,
embolize.
I think you need to ask an interventional radiologist that question, because many people didn't understand what TACE is when you're using a lipoidol. You can inject the whole thing into the right hepatic artery where there is a single tumor in a small part of the right side of the liver, where TACE will only be into the tumor, not to the rest of the right lobe of the liver. You won't occlude the whole of the right lobe of the liver by injecting lipoidol and doing a TACE on the right hepatic artery. That doesn't actually happen. So it's not that it will embolize every vessel that lipoidol is injected into. That is one thing. I think an interventional radiologist should answer that. And what I'm trying to say is there are 7,000 patients and 11,000 patients in these studies. So there are people who believe in it and who have done it as a TACE. So it's not something that we can take very lightly and say, I don't agree with it, because they have shown clearly an advantage of doing TACE as an adjuvant post-resection in patients who don't have.
It may be that they just spray some chemotherapeutic agent along with lipoidal without blocking the vessel. So this may be the. So I think
TACE is that. You don't actually have to block a vessel in a TACE. If you're injecting chemotherapy with lipoidol, it still is called TACE. And that's how the terminology TACE was originally used. It's not blocking the blood vessel. You don't have to block the blood vessel in a TACE. Okay. Okay, can I leave you guys to summarize? And I need to go as well. I'm sorry, I've just came out of theater for 2 hours. They want me there. Go on.
Oh, okay. Thank you so much, Professor Rela. I think it was a wonderful discussion and case presentation. Just to add to Professor Abbas, it may be a bit contradictory, but I'll just add that the overall name is chemoembolization, so it has a component of embolization, and now we are moving towards more and more super selective thing. It may be drug-eluting bead or conventional TACE, and even transarterial embolization is in vogue, and especially some centers still believe in it. So more so, we would like to see the articles where what part of the liver was embolized. Abbas has a point, like which part of the liver was embolized. Was it the same part which was resected, or was it the contralateral part, or both the parts were embolized? So those are the still questions which we need to answer before going by the concept. Yes, we agree that there is a concept, and definitely somebody has done, and it's quite a large number RCTs and many papers being shown. So yes, there is a concept. but need to see exactly what they are doing at. But thank you so much for your wonderful cases. It really added to the knowledge of panelists and definitely all the people who have joined this meeting. And over to Dr. Ashok Chaudhary for the proceedings.
Yeah, thank you. I think it is the case selection and the discussion was excellent. So with this, we are going to conclude this session. So Professor K, Professor Sinha, Professor Amar, and Professor and our panelists and esteemed members of this ALCAP, with thanks for this scintillating session and talks. So every month, second Tuesday, we go for this ALCAP session and continue years around. And with this, I think we'll conclude the session. Few questions left with, and I hope we'll reply to them. So one of my plan is that we'll come with a newsletter from in the next 1 or 2 sessions, so that we may take the case opportunities, the learning discussion points, and brief abstracts of the speakers from next session. So with this, I think we hope we'll cover ALCAP in a comprehensive way. And with this also, I thank all participants who were here. They will get the certificates from the APASL in their respective mail. So I think we'll close now. Again, thanks everyone for attending and spending their time. Bye. We'll see you.